Welcome to the discussion of the Uworld question ID 4750. The patient is a 62 years old female. She is non-smoker, non-alcoholic. Past medical history is significant for hypertension and long-standing diabetes. She takes lisinopril to control hypertension and metformin for diabetes. She is complaining of urinary frequency and burning with urination. So, the diagnosis of urinary tract involvement jumps up into your mind directly because there are urinary tract symptoms. You start analyzing these symptoms. The only analysis in the case given, the absence of fever, chills and back pain, nausea and abdominal pain. Fever, chills and back pain is the differentiating features of pyelonephritis. It helps differentiate it from cystitis. So they are absent, that excludes pyelonephritis. Nausea and abdominal pain absence to exclude GI causes of abdominal pain or these symptoms, urinary symptoms. Other things like the onset is not mentioned. The character is burning. Didn't mention if there is urgency or not. Urgency means the immediate need to go to the bathroom. It's also expected. By examination, you take the vitals. This is the first thing you do when you encounter a patient in the clinical practice. There is hypertension, slight elevation of the systolic blood pressure. It's 149, must be below 140, but it's increased, maybe due to age-related changes, or maybe it's related to lisinopril dosing problem. Maybe she needs to increase the dose or something. The pulse is 70. The temperature is not mentioned, exact number, but it was mentioned that there is no fever. I assume that the word no fever indicates the patient own words. Patient denies the presence of fever or chills, but they must give you a number to exclude pyelonephritis as the cause of urinary tract infection. He didn't mention anything about the rest of the examination, like suprapubic tenderness or flank tenderness. These things might help you differentiate between cystitis and pyelonephritis. And other things might show up in the examination, things related to hernia. If there's hernia or something, some sort of hernia or some types of hernia may cause urinary frequency. Where is the rest of the examination? Inspection, palpation, percussion, auscultation. I'm here speaking about clinical practice, not about a question in the question bank. I'm using it so you can manage a real case of urinary frequency and urgency. So you are thinking about urinary tract infection or urinary tract related thing. What you would ask for is urinalysis. You would also ask for CBC. Why would you ask for a CBC? It serves many purposes. First of all, she's an old age patient, so CBC would help if there's anemia or something. And given her postmenopausal age, postmenopausal women, premenopausal women are more prone to anemia. But if there's anemia in postmenopausal, that will be a little bit concerning. So you do a hematocrit, it's normal. White blood cells, it's also normal. And due to the urinalysis, the nitrates are present. These are signs of infection or a marker for the infection along leukocytes trace. There is an urinary tract infection. There is proteins, 2+ means there is 100 to 300 milligram per deciliter of excretion of protein in the sample. There are white blood cells, 20 to 25. The normal range is 3 to 5. Above that, this is abnormal. There is an infection, but it's not as severe or as systemic to cause fever or cause increased total leukocytic count. Renal function is also done. the creatinine is 1.1, which means that the renal function is normal, it's not affected. So you diagnose it as cystitis. Okay, you give trimethoprim sulfametoxazole. I'm questioning this because in other questions explanation you treat this case differently. Why am I saying this? Because she is diabetic. Diabetes is managed differently. Urinary tract infection in diabetics is managed differently. You should do a culture, okay, and you might use alternative therapy like fluoroquinolones. So this is the thing I'm questioning. They are asking about something for the sake of the knowledge or the facts, not giving an actual practical question, clinical practice. But here I'm speaking about clinical practice in real life. What would you do? They tell you that if in diabetic patient, you should do culture and give alternate therapy. In case of complicated cystitis, this is considered a complicated cystitis. So you'd give fluoroquinolones, for instance. Anyway, symptoms resolved. It can be helpful. Like even if you gave the drugs that in uncomplicated cystitis, it might be helpful. So the symptoms resolved anyways. But proteinuria persisted. So proteinuria is not related to the urinary tract infection. That's the thing. In this case, they are mentioning something, but at the end they're asking about something else. It's asking about what's causing this proteinuria. What's actually causing this proteinuria is diabetic nephropathy. There is a glomerular basement membrane changes. Clinically, what would that matter for you? The only thing that I think it would matter that if the patient asked you, okay, I'm fine now, the symptoms resolved, but my urinalysis came up with proteinuria. Tell me, doctor, what is the cause of this proteinuria? You would tell her, your diabetes might play a role in this. You wouldn't be mentioning glomerular basement membrane changes to her. Like, why would you do that? Why would you complicate the explanation to her? This is the bothering thing about this question. He's giving you a urinary tract infection, and then he's asking about proteinuria, a different aspect. And then that's why I don't like questions about pathophysiology. Okay, it's great to understand it, and it might be helpful in management and stuff, but in clinical aspect, what difference does it make for me? Anyways, this is the answer, and there was an answer about atherosclerosis and hypertension, and this was not the right answer because proteinuria is not expected in this case. This is the explanation. Anyways, this concludes our question. If you have any additions to what I said, do not hesitate to leave it in the comment section. Thank you and good luck.